Welcome back to the Atlas of Chiropractic podcast. Got a rapid research review. This one's going to be actionable. And what we're talking about here, I'll read from the title of the paper. And this is a paper from 2024, Journal of Orthopedic Surgery and Research, titled Effect of Long-Term Cervical Extensor Exercise Program on Functional Disability, Pain Intensity, Range of Motion, Cervical Muscle Mass, and cervical curvature in young adult population with chronic non-specific neck pain, a randomized controlled trial. So it's a little bit of a mouthful, but basically everything that they're measuring is in the title there. And what this study attempts to compare is, do folks that engage with a consistent exercise routine focused on cervical extensors do better than folks who just stretch their muscles for chronic non-specific neck pain? Okay, and I'm going to give you some key takeaways and a sample exercise program at the end of this presentation so that you can think about how you might apply it to upper cervical practice. But let's just get into the paper. Listen all the way through to get to that portion. Also, click the link in the show notes, get access to the paper, read the full text PDF for yourself. I'm just going to pull out the important highlights for the sake of a rapid review, but go ahead and, as always, get the paper for yourself. So what are we talking about in terms of the patient population here? Quote, non-specific neck pain stands as the fourth leading cause of chronic disability with annual prevalence rate exceeding 30%. Chronic non-specific neck pain is defined as pain persisting for more than 3 months or longer and is projected to affect 48 to 67% of individuals at some point in their lifetime. Right, so this is like a lot of our patients, right? Probably more than that, half to 2/3. If we were to do a assessment of our patient population, lots of them would fall into this category. Young adulthood, and this is also from the introduction, quote, young adulthood is a transitional stage between adolescence and adulthood and full social membership, introduces inequalities in socioeconomic status, simultaneously biological parameters such as bone mass, muscle strength, peak during young adulthood, rendering individuals vulnerable to future musculoskeletal health issues. And we understand in the progression of chronic pain, according to the modern understanding of pain science, that the more frequently folks have painful experiences, the more deeply that becomes ingrained in their nervous system, and the harder it is to break those cycles and patterns later on in life. So young adulthood provides a really, really interesting opportunity to intervene and help folks get off of that trajectory of chronic pain. And thoughtful strategies can go a really, really long way with this. So why cervical extensors? Quote, the cervical extensors were organized into 4 layers, with the deepest layer including semispinalis cervicis, multifidus, rotatories. These are key stabilizers for the cervical spine in terms of segmental support. Emerging evidence suggests that variable changes in cervical extensor muscles among individuals with chronic nonspecific neck pain. Remodeling of muscle structures such as large cross-sectional areas of superficial layer extensors and smaller CSAs of deep layer extensors, transformation from type 1 to type 2 fibers, and alteration in muscle behavior, increased or decreased activation. Furthermore, deficits in cervical muscle activity may lead to poor joint movement control, repeated microtrauma, and subsequent pain, resulting in decreased cervical range of motion and cervical lordosis loss. Again, a mouthful, but what are we talking about here? These cervical extensor muscles are really, really important for lots of parameters related to cervical spine health. Obviously, those deeper stabilizers, their role in segmental support is huge. And regardless of how you analyze, whether it's a articular or an orthogonal type of misalignment, we rely on the engagement and the support of those little segmental muscles to help stabilize the spine and help folks to hold their adjustments. Not only that, we deal with lots of folks that have more than just pain, right? Dizziness and headaches and things like that. Now, how does the deconditioning or the dysfunction of these muscles impact things like joint movement control, right? Repetitive microtrauma leads to things like degenerative changes in the spine. So it's a big deal. A lot of things that can happen when these muscles are deconditioned, injured, not working properly. This transformation from type 1 to type 2 fibers is really interesting because we can see that the actual structural characteristics of the muscles change when they're deconditioned. Moreover, that can lead to mechanoreceptors having a nociceptive impact, right? So all these things to say that when these muscles are dysfunctional, it can really hit the fan in a lot of ways and produce some significant symptoms for our patients. And it can start early in young adulthood. So for all those reasons, we care about range of motion, we care about stability, we care about cervical lordosis, and so these things play right into the hand of upper cervical chiropractic. So, who enrolled in the study? Individuals age 18 to 35 who visited a spinal surgical clinic for chronic nonspecific neck pain for more than 3 months were eligible for enrollment. So right away we're thinking, why in the world would someone of that age with just 3 months of neck pain be going to a surgical clinic, right? We want to be the first choice for these folks. And these were some of the other inclusion criteria. Folks that had a neck disability index greater than 50% and pain on the visual analog scale of 4 or greater out of 10, right? So that's at least moderate pain. They also looked at cervical radiographs and identified folks with a straight or kyphotic cervical curve. And so they talked about the methods that they used and the reference ranges for that. A little bit different than a Cobb analysis, but you can see in the paper how they went about doing that. And I really appreciated that they used X-ray and MRI as important outcome measures, because the only way to measure that cross-sectional area of those deep cervical muscles, even the superficial extensors, is to measure them on the axial image on a MRI, right? So we have radiographic evidence as well as quantified range of motion and pain and quality of life measurements with this. Pretty well-rounded, in my opinion. So let's talk about how many folks actually completed the study here. They started with a total of 145 eligible subjects, and by the time they finished their 12-month follow-up, only 48 had completed the 12-month follow-up. So the way this worked is they randomized the 145 people down into different groups. There was a control group and an observation group. The observation group was obviously the one doing the exercises. We'll talk about how they did that. But the control group was just doing basic neck stretches. Okay. And so the way that this worked out is, I don't know why, but they started with ibuprofen, right? They gave them a week's worth of anti-inflammatory, pain medications, just to, I guess, get everybody on the same pain threshold to start the process. And then for the first 9 months, participants visited the clinic and performed the exercises under instruction. Then for the last 3 months, they did the exercises at home. I'm not suggesting you need to have people come in and watch them exercise every week for 9 months, but you get an idea of how the study was performed and why they ended up with only 48 of the 145 that completed it. So what did the control group do? This was this stretch group. So they were asked to sit on a stool, rotate the head freely for 5 minutes. This was considered their warm-up, just move your neck around. And then the actual warm-up included neck bending exercises 15 times, 4 sets each in different directions. So basically just flex, extend, laterally flex, and rotate 15 times each way. Then a 10-minute supine manual tractioning, which if you can see on the image here, if you're looking on YouTube, go check that out. You can see the images of how this was performed. But basically like a gentle y-axis distraction type of thing. The examiner has their hands under the occiput, the patient supine, and they're basically just kind of gently pulling up to distract the neck. So that's the control group. They're basically just moving their neck around, doing some gentle stretching. The observation group, the exercise group, did 2 types of exercises. They did isometric and isokinetic exercises. The isometric training focused on deep cervical extensors and was performed like this. The participant sat upright in a chair, hands folded and placed slightly below the occiput, so basically clasped their hands together on their neck and pushed against the resistance applied by their hands. So they were instructed to hold that for as long as possible. When they fatigued, they could take a 30-second break and then just rinse and repeat for a total of 15 minutes of isometric exercises. After a 5-minute rest, then they did the isokinetic exercises, which was band-resisted cervical extension. So to perform this one, they had folks in a kneeling quadruped position with a elastic band under their hands and then up to the back of the head, and they would perform a band-resisted neck extension exercise for sets of 15 reps with an even speed, 4 total sets, 30 seconds in between, and then they ended with the same manual tractioning thing. So they warmed up the same, they ended with the same tractioning, but what they did in the middle was the difference. So the isometric and isokinetic exercises compared to just basic cervical spine range of motion stretches. So there were outcome measures measured at 3, 6, and 12 months after the trial started. So they looked at those pain parameters, they looked at the cross-sectional areas of the muscles on MRI, and they measured the angles of the cervical lordosis at each of those intervals, which I think is a pretty cool way to track progress, both structurally and functionally. And let's get into some of the results. And I'm not going to go through every little itty bitty detail in this study, so go ahead again, read it for yourself. But the thing that I think is most interesting is the way that they measured the cross-sectional area of the cervical extensors. So just to give you an idea of what muscles are we talking about here. Cervical multifidi, the semispinalis cervicis, semispinalis capitis, splenius capitis muscles. They did this on a T1 weighted axial magnetic resonance image, right? So they did a T1 MRI. They took an axial slice at the mid-disc level through each of the motor units of the neck, so C2, 3, C3, 4, 4, 5, 5, 6, and 6, 7. And they used the sagittal to find that mid-disc level, pulled their axial slice, and measured those cross-sectional areas. So if you're watching on the video here, you can see on the screen a sample of that axial slice on the T1 image, and you can see they outlined here those 4 different muscle groups. So we've got the multifidus here, number 1, semispinalis cervicis, number 2, semispinalis capitis, number 3, and then splenius capitis, number 4. So from deep to superficial, okay? This also shows the way that they measured the cervical lordosis using that tangent line method. So let's compare outcomes for the control stretch group and the observation or exercise group. When we look at the visual analog scale and pain, the participants in both groups demonstrated improvement in neck pain at each follow-up time point. Okay, so assessed by that visual analog scale, both groups felt better each time they came in for the 3, 6, and 12-month follow-ups. Regarding the measurement of cervical range of motion, both groups again showed improvement at each follow-up time point. So in both of those regards, so far no distinguishing features as far as which is better. When we look at the cross-sectional areas of the extensors, this is where it starts to become more interesting. The participants in the control group showed a slight increase in muscle areas at each follow-up from baseline, particularly from 6 to 12 months. In contrast, the participants in the observation group had a greater increase of CSA of cervical extensors at every follow-up from baseline. So the idea was, okay, the neck stretch group, they're feeling better. They're just moving their head and neck more during the day. So we will attribute the changes that we saw in the CSAs, the cross-sectional areas of those muscles, to just basic physiological activation, more so than the control group or the observation group, which showed more significant improvement in those cross-sectional areas of the muscles. So what does that mean? It means the muscles are getting bigger as they're exercising, right? We understand that that should happen. As regards to the cervical curvature from baseline, no significant differences were observed in the population of participants with cervical lordosis between 2 groups at each follow-up. However, a marginal non-significant difference between the 2 groups was found at the last follow-up for the observation group, meaning not major changes in the cervical lordosis at each of those intervals for both groups, but by the time they got to the 12-month follow-up, the observation group was doing a little bit better in their cervical lordosis, but the differences between the 2 were not substantially different. So getting into some discussion points here, and then we'll go into key takeaways for upper cervical chiropractors and a sample exercise program that could be used in an upper cervical setting. Quote, an easy, implementable, and effective exercise program would ideally reduce occurrences of neck pain and its consequences in adulthood. Our 12-month follow-up results have validated our hypothesis that in the young adult population with non-specific chronic neck pain, a long-term specific training exercise of cervical extensors is superior to usual stretching exercises in improving pain, disability, and cervical range of motion, and increasing cervical muscle cross-sectional areas. So, surprise, surprise, exercising the muscles outperformed basic stretching. And quote, our findings support the notion that specific extensor exercises are superior in long-term pain and disability impairment, as significant between group differences in NDI and VAS scores were only found at the 12-month follow-up, right? So basically what that means is for the first 3 to 6 months, I mean, both groups were tracking pretty closely, but at 12 months, the folks that were exercising, that's where they really leapt ahead in terms of their results. Quote, in the observation group, a noteworthy increase in the CSAs of cervical extensors was observed at each follow-up, encompassing both superficial and deep layers, right? So what does that mean? At the 3, 6, 12-month mark, there was a significant increase in the cross-sectional area of the extensors. Those muscles were growing throughout the course of a year by the training. And now the isometric and the isokinetic exercises obviously targeted all of those layers from deep to superficial, which is huge because that gives us that segmental stability that we want, helps with motor control and movement sense, helps keep those muscles in the correct fiber types, helps reduce fatty infiltration, and so on and so forth, right? So having healthy muscles is huge for long-term health of the neck. So what happened in the control group with the cross-sectional areas? Well, we said earlier that there were marginal improvements at 6 and 12-month follow-ups, indicating that stretching alone might not be significant for muscle mass gain. We infer that the observed increase in muscle size among participants in the control group was just based on the alleviation of pain and improvement in disability, leading to enhanced daily neck movements and strengthening of neck muscles. So basically, it just got them back to a physiological baseline of muscle health, but didn't build any capacity. In this trial, 28% of participants in the observation group restored cervical lordosis, compared with 9% in the control group at the 12-month follow-up. So this is also a really interesting finding in that by the time they were a year down the road, the folks that had been engaged in that cervical extension exercise program, 1 in 3 of them had restored their cervical lordosis, compared with only 1 in 10 that would have at the in the control group with stretching. So these findings align with the findings of Yoon et al.'s trial, where they observed no correlation between the cervical lordosis angle and individual neck muscle CSAs. However, there was a positive correlation with the ratio of flexor to extensor muscles. These results suggest that restoring the balance between flexor and extensor muscles may be crucial for maintaining the physiological cervical lordotic curvature. Okay, so if you are someone who is taking a lateral and you're telling a patient, hey, we see here that your neck is straight or it's kyphotic, it's not showing the curvature that we'd expect. What we're understanding here from these two studies is that the balance of the neck muscles around the neck is what's important for the maintenance of that physiological lordosis. So often folks are deconditioned, right? They have a loss of capacity in those cervical extensors. And again, this is a young adult population. This isn't like in a geriatric population where there's general deconditioning. So again, early intervention in this group help restore that balance, help restore that physiological lordosis is only going to benefit folks long term. In conclusion, our findings indicate that specific cervical extensor exercises are superior to usual stretching exercises in alleviating neck disability and pain, enhancing cervical range of motion. Furthermore, specific training of cervical extensors in young adults significantly increases muscle mass, potentially contributing to the restoration of cervical lordosis. For me, that's compelling enough to go ahead and implement some of these findings. So let's talk about the key takeaways and a sample exercise program for upper cervical chiropractors. So go over to the Atlas of Chiropractic YouTube channel if you're not there already and look at what we have here. But in summary, here are my key takeaways for upper cervical chiropractors. Low tech, low skill exercises can supplement your care and enhance your outcomes. Increased CSAs, cross-sectional areas of extensors, and decreased fatty infiltration are correlates to long-term neck health. So we want to restore that balance. Consistency is key, right? Patients need to own and participate in their outcome. And for folks to achieve these benefits, they had to be engaged for a year, right? They had to really contribute to their outcome and to do things consistently that are good for them. And so lastly, intervening in this young adult population with thoughtful care and supportive strategies can improve their health trajectory, decreasing risk of injury and improve quality of life. And I think we would all agree that that is a huge win for a patient in a chiropractic office to achieve those things. So, sample exercise plan for a UC patient. Now, some of you might be listening thinking, I don't even know the first thing about how I might implement something like this. Are those exercises going to upset their adjustment? Is it going to, at what point in the process would I start to do something like that? So to answer those questions, let's just give you a framework. There's some ideas to think about that. When might you start to implement something like this? I would suggest for the first 4 weeks of their care, just check and adjust only. I don't know how each and every person structures their care plans, or, how you go about programming care for patients. But I would suggest that spend that first month at least, check and adjust only, right? And then do a progress exam. Make sure that your upper cervical progress is on track, and keep it focused on those key things related to your technique parameters early on. So let's say you do that. Let's go for the next few weeks. Let's say weeks 4 to 6, implement those warm-up exercises, those range of motion exercises, those seated extension isometrics. Now let's kind of wade into the waters carefully, understanding that it's going to take a year. So let's build up over time with simple strategies starting. So just like they did in the program, you can instruct your patient on how to just do a seated neck isometric hold. And what they had folks do was 15 minutes. You might not necessarily do that much. Maybe you start with 3 sets of 45 to 60-second holds with 30 seconds rest in between. And you do a few of those a day, 3 times a week, right? And then let's move on to week 6 plus 12. Let's say that they're holding their adjustment. They've done their isometrics. How do we progress them? Weeks 6 through 12 plus, do the warm-up as demonstrated, do the isometrics that we started with before, and now let's increase the level of difficulty with that band-resisted neck extension. Now in my office, I just use a green TheraBand. You could buy a big roll of it on Amazon, cut it into 3-foot sections, and give it to a patient to use at home. And let's say, according to the research here, they did 3 sets of 15 reps, 30 seconds rest in between, right? You might start out in a seated or standing position, performing those neck extension exercises, holding the band against the back of the head. And then you may progress to that quadruped position where they had them on their hands and knees, adding the effects of gravity and holding the neck out while they perform the exercises, right? So you can see there could be a progression to this. And again, 3 times a week plus for all these things. They had them do 3 times a week for a year. So that would be your bare minimum. I would encourage folks to do it every day, hoping that you get 3 times a week, because as we learned from the study here, compliance is key, and it's also a challenge. So tips: demonstrate, right? You're going to show people how to do this. This isn't like a sheet of paper you hand them and then say, here, go do this for the next year. Right? You need to go be a leader, demonstrate the action that you want them to perform, practice what you preach, have them do it in front of you. So test it, see how it feels, refine their movement, make sure that they're understanding what they're supposed to accomplish, and give them positive reinforcement. Hey, that looks good. I think this is going to be really good for you. You pretty much nailed that. Or we made a couple refinements. You're feeling it. You're getting it. It's starting to click. This is going to work well for you, right? Encourage them that this is good stuff. If you need to, have them grab their phone, record a video of you performing or explaining the exercise for them to reference, right? You can record a video of them doing the exercise for them to reference if you need to, but just make it visually compelling and appealing, and have a way for them to reference later exactly how it's supposed to work, so that they don't forget and become embarrassed to ask you about it again and just not do it. Check in frequently, right? We understand that compliance is everything with this. Every time they come in, how your exercise is going, how they feeling, how are you progressing with them? Are you getting them done, right? Do you need to review that? Do you feel confident you know what to do? Do you want to make it more difficult, right? Just check in on this stuff and make sure that you are allowing the patient to be accountable to what you have suggested is in their best interest. And lastly, reinforce long-term benefits over short-term relief. Look, both of these groups, whether they stretched or exercised, they both felt better within 3 months, right? And that's true for a lot of non-specific musculoskeletal pain syndromes. If you just start doing something, you're probably going to feel better. But we understand that's not what this is about, right? And it's really not all of what upper cervical care is about. It's about enhancing capacity. It's about actually being better more than just feeling better. So reinforce that, hey, we're doing this so that your neck muscles are healthy and go the distance, right? You want to be able to rely on them. God forbid you get in a car accident. As you age, you can stay engaged in your activities. You don't have recurrence of these episodes of chronic pain, right? So I tell folks in here all the time, exercising muscles helps them not get fat, right? You want marbling in your steak, not your neck. And so again, we're thinking long-term with this. And as you're checking in and encouraging folks, remind them that this is a long-term practice. If they're doing other fitness types of activities, just figure out a way to work it into what they're already doing so that just becomes routine. And remember, healthy necks feel better, but not every neck that feels good is healthy. So emphasize that this is a functional outcome more than a feeling outcome, and you may have to navigate how and when you can implement these strategies for different types of patient populations. So as always, it doesn't absolve your responsibility to be the doctor and implement these strategies thoughtfully. But I hope that you found this brief sample exercise plan useful as a framework to start thinking through how you may implement the findings of this research into your day-to-day practice. If you have questions, concerns about that, reach out, blairchiropodcast@gmail.com. Click the link here in the show notes to access the full text of the paper. Read it for yourself. Connect with me on Instagram. Send me a message to ask specific questions, or leave a comment here on YouTube to carry on the conversation. But all of this is in an effort to enhance our care and to help our patients live a better life and be better by knowing us as and trusting us as their chiropractor.